Welcome to this review where we are going to review the infrahyoid anterior neck triangles. This is an assumption that you have already listened to the main lecture on the infrahyoid anterior neck triangles. It was a long lecture, but I believe that you found time to listen to it and cover its content, because this is just a summary of that particular lecture. So we start by just reminding ourselves that the anterior neck triangle is bounded by the following: the anterior border of sternocleidomastoid, the midline of the neck, and the inferior border of the mandible. Those are the boundaries of the anterior neck triangles. We divide this anterior neck triangle into 4 smaller triangles using the digastric muscle, both its anterior belly as well as posterior belly. Also using the stylohyoid muscle, it doesn't have more than one belly, and the superior belly of the homohyoid muscle. The triangles that we look at are the muscular triangle there, or this one, the carotid triangle, which is that one, and those two are the ones that fall below the hyoid bone. Therefore, they're the ones we are calling the infrahyoid anterior neck triangles. And those are the ones we are going to focus on in this particular session, or at least the ones that the lecture you listened to focused on. But then we also have 2 other triangles. The digastric triangle is that one, and the submental triangle is that one. We will cover those ones when we look at the suprahyoid anterior neck triangles, and as well as the suprahyoid neck spaces. So our focus would be on the muscular triangle and carotid triangle. Let's start with the muscular triangle so we can give its correct boundaries. We have the superior belly of homohyoid, the anterior border of sternocleidomastoid muscle, and midline of the neck. Those are the boundaries of the muscular triangle of the neck. In terms of its contents, the major content are the infrahyoid musculature. When you talk of infrahyoid musculature, we're referring to these muscles which are below the hyoid bone. Generally, we term them as the strap muscles. They are responsible for moving the hyoid bone downwards, but they also move the larynx either down or up. 4 muscles belong to this category of infrahyoid muscles, so the strap muscles. You have the homohyoid muscle. Remember, homohyoid muscle is also a boundary of the muscular triangle. We have the sternohyoid muscle. That one comes from the sternum to the hyoid. Now, those 2 are termed the superficial infrahyoid muscles. And then we have the sternothyroid. So from the sternum to the thyroid, that one. And lastly, we have the thyroid. That is from thyroid to the hyoid. So those 2 are the deep strap muscles. Remember, in terms of their nerve supply, branches of the ansa cervicalis, what supplies them. It will be important that you remember the actual action of each of the 4 muscles we've mentioned. Other than the strap muscles, the anterior triangle in particular, the muscular triangle of the neck, houses deep to these muscles the visceral components of the neck. So the cervical viscera in this category constitute things like the thyroid gland, the parathyroid gland, the trachea, and the esophagus. They are deep to the muscular triangle. It is for that reason that this particular content also had something to do with thyroid and parathyroid gland. And so let's talk about thyroid and parathyroid gland. We start with the thyroid gland, enclosed by the middle layer of the deep cervical fascia. That is the blue one. Remember, the middle layer of the deep cervical fascia is what is sometimes known as the visceral fascia of the neck, or loosely called the pretracheal fascia. The pretracheal fascia encloses the thyroid gland, as we can see in that particular image. In terms of its location, the gland is located in the anterior lower neck in front of the trachea. Remember, it has two lobes, which are somewhat pyramidal and, somewhat is conical in shape with an apex up there and a broader base down here. And then we have the isthmus of the thyroid gland, which is somewhere here. And occasionally you may have a pyramidal lobe of the thyroid gland. When present, it should be attaching on the isthmus, projecting upwards, and will be more to the left. Usually it's more common on the left than on the right. It is expected that you do remember the extents of the lobes as well as the extents of the isthmus. So remember, the lobes extend from the oblique line of the thyroid cartilage there up to around the fourth, the fifth tracheal ring down there. The isthmus will overlie the second, the third, and perhaps the fourth tracheal ring in front here. In terms of relational anatomy, the relations of the isthmus can be considered as anterior relations, posterior relations, superior and inferior relations. So anteriorly, you'll have the anterior jugular vein and the strap muscles. Then posteriorly, you have the second to fourth tracheal ring. Superiorly, you'll expect the superior anastomotic artery, and inferiorly, you'll expect again some blood vessels down. The lobes are related to a number of structures. The best way to describe relation the lobes of thyroid are based on their surfaces. Anterolateral surface is the superficial surface, so this is where you expect many structures, and you can see them in this particular list. Some of them are the strap muscles, but of course we still have the anterior jugular vein and an overlap of sternocleidomastoid muscle there. Then we have relations of the posterolateral surface. This is largely the contents of the carotid sheath. Then you have relations on the posterior border, and this will put mainly the parathyroid glands. Then you'll have the relations of the medial surface, and the relations of the medial surface are best classified in terms of the rule of twos. Two tubes, that will be so one of the tube is the trachea below and the larynx above. That is one tube, but two structures we mentioned. The second tube is the esophagus on the lower side and the pharynx on the upper part. That's the second tube, but again, we've mentioned two things there. Other than two tubes, you also have two nerves. The recurrent laryngeal nerve, and we also have the external laryngeal nerve. Then there are two muscles as well. The cricothyroid muscle and the inferior pharyngeal constrictor muscle. That inferior pharyngeal constrictor muscle has a part that we call the cricopharyngeus part. So that's the part we're talking about. So remember the rule of twos when we describe the medial relations of the thyroid lobes. The other thing that needed to be a take-home message is the blood supply to the thyroid gland. The constant arteries would be the superior thyroid artery, which arises from the external carotid artery. It's actually the first branch of the external carotid artery. It divides into anterior and posterior glandular branches, and each of the glandular branches anastomose probably with the contralateral side, in which case the anterior glandular branch of the right and the left are the ones that form the anterior anastomotic artery above the isthmus. We have the inferior thyroid artery, which is from the thyrocervical trunk, which is from the first part of the subclavian artery. That one also supplies the gland. It gives you some posterior and ascending branches to the thyroid gland, supplying the lower parts of the gland. The inconsistent artery is the thyroidema, which may also supply the thyroid gland. There are three veins which drain the gland: superior thyroid vein into the internal jugular, middle thyroid vein into the internal jugular, and inferior thyroid veins which go to the brachiocephalic veins. There are multiple veins, and sometimes they all drain into the left brachiocephalic vein because the one that crosses the midline. Other than the thyroid gland, you're also expected to know about the parathyroid. Maybe before we exit that scene of the thyroid, remember the cell types within the thyroid follicles, or rather the cell types of the thyroid gland. We have the follicular cells which produce T3 and T4, and parafollicular cells which produce calcitonin. Now here we are at the parathyroid glands. There are usually 4 superior and inferior parathyroid glands, as we can see them located behind the thyroid lobes. Histologically, it will be an ovoid structure embedded within the thyroid, as we can see. So in this particular image, we can use this slide to describe histology of the thyroid gland itself, as well as histology of the parathyroid gland. Starting with that of the thyroid gland, we see that thyroid gland has several spherical to ovoid structures, which we call follicles. Each follicle consists of a central colloid material, which is the iodinated thyroglobulin, the storage form of T3 and T4. And this is surrounded by a ring of follicular cells, which you can't see because of this magnification. The follicular cells are the one that secrete T3 and T4. Remember, they are very tall when the gland is active, but short if the gland is inactive. In that case, if the gland is inactive, also the colloid material will be a lot. Between the follicles, you have parafollicular cells which secrete calcitonin. We may not see them in this magnification. Now, parathyroid gland in itself is highly cellular. It's a cluster of cells surrounded by a very thin capsule, as you can see there, embedded behind thyroid. Parafollicular gland also has a number of cell types. You remember we have the adipocytes, the oxyphil cells, the clear cells, and the principal cells. Remember, the principal cells, also known as chief cells, are the ones which produce PTH, parathyroid hormone, which is also important in calcium metabolism, just like calcitonin. Then we talked about the carotid triangle of the neck. So carotid triangle of the neck is bounded by anterior border of sternocleidomastoid, the superior belly of omohyoid, and anterior superiorly there, we have 2 muscles: posterior belly of the digastric muscle and the stylohyoid muscle. The floor of the triangle has a number of muscles as well: the inferior pharyngeal constrictor, the middle pharyngeal constrictor, the thyroid muscle, and the hyoglossus muscle. The roof, remember, is covered by the muscle platysma, but on that roof, we also have the subcutaneous structures like the transverse cervical cutaneous nerve, which is from the cervical plexus. And you may also have some veins traversing that superficial, just like in the muscular triangle, we'll also have them. Now, contents of the carotid triangle are quite important. We have the carotid arterial system. We also have running with it the internal jugular vein. We do have some cranial nerves, number 9, 10, 11, and 12. And then we also have the sympathetic chain, which is part of the neural elements within the carotid triangle. Remember that at the carotid bifurcation, we have the carotid body and the carotid sinus. And at the entry of the internal jugular vein to the jugular foramen, we also have the jugular bulb, which is also a chemoreceptor zone, just like the carotid body. Now, what is expected of you regarding the contents of the carotid triangle is a bit extensive. You knowing much anatomy about each of those contents of the carotid triangle is important. So for common carotid, about its origin and its course, remember on the right side, it is brachiocephalic trunk, on the left side is aortic arc, its course within the carotid sheath, and then the level of bifurcation, which I hope you do remember. Common question will ask you. At the bifurcation, we have the internal carotid artery and the external carotid artery. Remember, external carotid is initially anteromedial, then it changes its orientation. For external carotid artery, supplies the external extracranium, so to speak, has anterior branches, posterior branches, medial branches, and terminal branches. You're expected to classify their branches as that way so that you remember them. The anterior branches are 3, posterior branches are 2, medial branches 1, terminal branches are 2. And I believe you can fill the gap for each of those branches in terms of their territory. For internal carotid, it doesn't have any branch in the neck, but when it enters, it has quite an extensive course. And that brings us to the segments of the internal carotid artery, which is important for you to remember. Remember, there are 2 ways of classifying the segments. You can look at them from a historical point of view for segments, but you can also look at them from another classification, which recognizes 7 segments. And that one is more radiological, more clinical, and perhaps the updated version of the segmental anatomy of the internal carotid artery. But for its basic understanding, remember, cervical segment is in the neck. Then the region within the carotid canal is the petrous part. Then the region going through the cavernous sinus, the cavernous part. And then the region beyond that is the cerebral part, or the terminal part. Each of those segments will have some specific branches, which are expected again to remember. Regarding carotid sinus, it's a baroreceptor zone, which is present on the wall of the initial segment of the internal carotid artery. Immediately it's formed, there's that ballooning region, which is called the carotid sinus baroreceptor zone. Carotid body is a highly vascularized and innervated structure between the 2 terminal branches of the common carotid, so at the carotid bifurcation. This is a chemoreceptor zone. Remember the cells there, the glomerulus cells, very important. They're the ones which are sensory receptor cells, but also chemosecretory. They secrete some chemicals. Similar to that is actually also the region of the jugular bulb, where we have the glomus jugulare also having a similar function as carotid body. So with internal jugular vein, it's formed from a continuation of the sigmoid sinus down, but you can also look at it in terms of union between sigmoid and the inferior petrosal sinus at the level of the jugular foramen. Remember, it has 2 bulbs, the upper bulb and the lower bulb. The upper bulb is related to the glomus jugulare, and the lower bulb is largely because of the valve that is proximal to it just before its termination. It terminates by joining the subclavian vein to form the brachiocephalic veins, right and left. Remember, at that union, then we have some lymphatic channels joining in that particular region, and the left is different from the one on the right. For the cranial nerves, 12 is the one that goes to the tongue to supply mass of the tongue, but it has communication to the cervical plexus, C1 largely, and that is why, therefore, there's some connections with it that also extend to supply the posterior craniodura, but also supplying the mass of the neck in form of the superior root of the ansa cervicalis. Number 10 is vagus, quite extensive distribution, but initially running within the carotid sheath. It has branches in the neck and it continues down to the thorax and the abdomen. You're expected to remember the different branches of the vagus nerve. In the neck, remember that it gives you the superior laryngeal nerve that will give you internal and external laryngeal nerve. It also gives you some cardiac nerves, which provide parasympathetic supply to the heart. And it also gives the recurrent laryngeal nerve lower down, which comes back to supply the larynx. Its pharyngeal branch also contributes to the pharyngeal plexus. Remember, vagus has connections with the cranial accessory nerve. And so through that pharyngeal branch, the cranial accessory nerve is able to supply muscles of the fourth pharyngeal arc. The glossopharyngeal nerve itself is the nerve of the third arc. It winds around the styloid process and supplies a muscle, stylopharyngeus. Then the glossopharyngeal gives you branches to the carotid bifurcation, very important, which are visceral afferent branches, basically, carrying sensory information from carotid body and sinus. The glossopharyngeal nerve also supplies the posterior 1/3 of the tongue, both general sensory and taste function. We also talked about the nodal anatomy of the cervical lymph nodes. And here you're expected to remember the levels of organization of the cervical lymph nodes. What I gave you in the lecture is a very updated version of the level anatomy. But if you can understand the first 6, it will be very important for you. Remember, level 1 is in the submental submandibular region. Level 2 is the upper jugular chain of deep cervical lymph nodes. Level 3 is the middle jugular chain of deep cervical lymph nodes. Level 4 is the lower jugular chain of deep cervical lymph nodes, as well as the medial aspect of supraclavicular nodes. Level 5 are the ones found in the posterior neck triangle. And level 6 are found in the central neck, in the anterior neck triangle, so largely around the cervical viscera there. Level 7 is contentious, depending on which emphasis you want to put. So you may want to look at it as radiologist and you say, find level 7 at the nodes just in the suprasternal region, in the anterior mediastinum. You can also look at level 7 as prevertebral if you're an oncologist, or you look at level 7 as the retropharyngeal nodes if you're a head and neck surgeon. So just understanding of what level 7 is contentious. That's why I'm saying if you understand from number 1 to 6, that would be good. Remember, in the latest version, there are also level 8 to 10. And those ones take you a bit up, now not down, but a bit up. You can see where level 8 is, around the parotid region, level 9 within the face and the malar region, and level 10 retroauricular there. All right. You also talked about the neck spaces. The understanding about the neck spaces is largely radiological and important, because when we image the neck, we don't image the neck in form of triangles. We image the neck in form of axial slices, transverse sections of the neck. So we see everything in one transverse or axial plane. So with that, it is important that we understand the neck spaces. The neck spaces come about as a result of the fact that the deep cervical fascia has several layers, and so it compartmentalizes regions of the neck. We have 3 layers of the deep cervical fascia. Superficial layer of the deep cervical fascia is the one that appears red here. It is called the investing fascia of the neck. The mid layer of the deep cervical fascia is the one we can call blue, if I'm right. And that one is the one we call the visceral fascia. or otherwise called the pretracheal fascia. Then the deep layer of the deep cervical fascia is the one in green, which we call the prevertebral fascia, although that term may also be a bit loose because the fascia goes round. Anyway, these three fascial systems meet around the common carotid, internal carotid, and form a sheath around it, which constitute, therefore, the carotid sheath. So carotid sheath is formed by union of the three around the carotid triangle, around the great vessels of the neck. So with that understanding, we have several spaces. The visceral space. The visceral space is this one, surrounded by the mid layer of the deep cervical fascia, housing the trachea, esophagus, thyroid gland, parathyroid gland, recurrent laryngeal nerve, and some lymph nodes. The carotid space is this one here, enclosed by the carotid sheath. It houses the common carotid artery, internal carotid artery, internal jugular vein, vagus nerve. Of course, some lymph nodes will also be there. On its upper part, if you're looking at the suprahyoid component of the carotid space, then we'll also include some other nerves, like we can include number 9, number 11, and number 12 being part of it, but those ones don't extend below the hyoid. So they're suprahyoid, but they're not infrahyoid. That brings me to a concept that I was forgetting, but I've now remembered, that some of these neck spaces extend superiorly beyond the hyoid, and carotid space is one of them. And some of them also extend beyond the neck down into the thorax, and there are quite a number that do that, even from this view. The third space to talk about is the paravertebral space, which is this one here. Now remember the paravertebral space, now call it paravertebral, not prevertebral, but paravertebral space, has two compartments. The anterior compartment of the paravertebral space is what we call the prevertebral space. Then the posterior compartment of the paravertebral space, this one, is what we call the paraspinal space. We are looking at the junction of the two being at the level of the tips of the transverse processes of the cervical vertebrae, because that marks the attachment of the paravertebral fascia. The other space is the retropharyngeal space, labeled 3 there, or in this particular region, we can see the retropharyngeal space there. So the retropharyngeal space is a small space, largely potential, between, or rather behind the cervical, the visceral space. Don't confuse the retropharyngeal space with the danger space of the neck. And in the lecture, I gave you the junction between the two. I hope you do remember the name of this fascia there. This is the prevertebral fascia, that fascia there, which is the alar fascia, and this one, which is the visceral fascia, distinguishing the spaces. So this is the danger space, then this is the prevertebral space, and that is the retropharyngeal space. All right, then lastly, we have the posterior cervical space, labeled 4 there. The posterior cervical space is generally this space here that would be corresponding largely to the posterior neck triangle. So it will contain whatever we expect with the posterior neck triangle: spinal accessory nerve, lymph nodes, the brachial plexus. All right, those are the neck spaces, and especially the infrahyoid neck spaces. So that summarizes for us what you're supposed to learn in that particular lecture. Thank you very much.